Hi everyone, my name is Ian Fen, physiotherapist from Parkinson's Society Singapore. And in this module, we will be talking about the interpretation of assessment findings and class stratification. If you have your training booklet with you, you may refer to the module CE3. And the objective of this module is for you to identify the problem list of your client based on the assessment findings, as well as to establish the physiotherapy goals for your clients, and last but not least, to stratify the clients into different exercise class level. In order for us to come up with our client's problem list, it is important for us to make use of the ICF model. And based on our subjective and objective assessment findings, as we have gone through in the module CE2, we should be able to identify the impairments, the functional limitations, as well as the participation restrictions of our clients with the ICF model. And first and foremost, we will talk about the body function and body structures of the ICF model. For body function, it is referring to the physiological functions of our body system. And as we know, the body structure is the anatomical part of our body, such as our upper limb, lower limbs, our organs, etc. So any deviational loss is actually called an impairment. So some of the common impairments that we do see in our clients includes a reduction in muscle power, and this can be assessed during your MMT. More often than not, they may have some impaired muscle tone, such as having dystonia, having rigidity. They may also have impaired movement reaction, and we are talking about them having poor balance reactions, or they may have impairment in their gait function. This is very common. They may have freezing, they may have reduction in arm swing, some reduction in trunk rotation, slowness in their gait speed. They may have hypokinesia as well. And another common impairment will be impaired involuntary movements. We are talking about things like having tremors or even having dyskinesia. And all this information can be picked up when you are performing your objective assessment. Some common impairments in non-motor functions includes mental components such as maybe your client's baseline, they may have some dementia or having some delirium. They may have personality issues such as low mood, or they may not be very confident when doing certain tasks, or they have motivation issue, they're not so motivated, or they do have a bit of impulsiveness. Some clients may have sleep deprivation or sleep issues, and some may have some attention problem as well, or memory issues, and most of them may have some sort like anxiety issues as well. And next, we're looking at some of the sensory and pain problems. Some of our clients do complain of dizziness. They have proprioception problem, complaining of numbness, tingling sensation, or any central pain problem. Some of our clients have some voice or speech problem. They may not be able to speak properly because of reduction in their speech, reduction in their voice volume. They are unable to articulate very well. The fluency and flow of their speech is not so good. Next, they may have some cardiovascular or respiratory problem, and which may result in a reduction in exercise tolerance. The exercise endurance is not that great, and they may also have postural or orthostatic hypotension because of this. Next, we will be looking at the activities of the ICF model. In this, we are looking at the ability to execute the task or the action, and we are looking at activity as a whole task, and not into specific individual structures or body function. So when a client has a problem executing certain activity, we will call it as activity limitation. Some of the examples of activity limitations in people with Parkinson's includes having issues with problem solving, or they may have issues making certain decisions, and they may have problem acquiring new skills because of things like reduction in safety awareness, safety insights, or generally they just have problems with problem solving. All right, they may also have problem with general tasks or general demands because they lack of the skill to do a task. They have problems with multitasking as well. All right, and most commonly, our clients do have issues with their mobility, which itself is an activity. All right, and they do require assistance in their day-to-day activities such as self-care, such as tasks like walking, standing, getting in and out of bed, and etc. So there are various activities that one can perform, and in this slide I would like to focus on the mobility task and how we should be using the ICF model, so we can see that the activity limitations is actually closely related to the impairments that we assessed. Alright, some of the most common mobility that our client will need to perform on a day-to-day basis would be like turning in bed, getting in and out of bed, sit to stand, and also walking. So as physiotherapists, we like to break down tasks into smaller components, right? So for example, when we are observing our clients turning in bed, we realize that, hey, they are lacking in certain components of that task. So then it is important for us to look for the reason why. Why are they unable to perform certain components? So for example, if they are unable to bend their knee during turning, why is that so? Is it because really that the knee flexors are weak? Or is it because they have lack of range? Maybe because they have OA knees, they are having painful knees. They have a certain limitation in their knee flexion range. Alright. And maybe why they can't reach over using their upper limb. You know, when we turn, we need to reach over using our upper limbs. We need to push a little on their heels. We need to perform somewhat like a truncal rotation. So why can't they reach over with their shoulder, performing a shoulder flexion? So is it because of again a lack of range? Is it because of strength issues, etc., etc.? All right. So these are certain questions that we need to find out. So let's pick another example, like sit to stand. So this client is having issue performing this activity. They need assistance during this activity, and they realize that, oh, it's because maybe they can't bring their legs in when they stand. All right, that's why they're unable to complete this task. They just can't bring their legs in to stand. All right, and then the reason, why is that the reason? So why are they unable to bring the legs in? Why are they having problem, for example, bringing their truncal forward? Is it due to physical issue, physical limitations that they can't bring their truncal forward? Or is it because of psychological reason, which is fear of falling? That's why they are just fearful of bringing their trunk forward. So similarly, the lack inability to push up from sitting to standing, is it really a strength issue? Or is it maybe because of hypokinesia? All right, these are certain reasons, there's certain things that we need to find out. So it is important for us to pick up the activity limitations, and from there we need to know what are the impairments of our client. And only by identifying the right impairments, that's when we can choose the best intervention to perform. So for example, if we realize that our clients are unable to perform certain components because of strength issue, okay, and that's when this client will need some strengthening intervention. All right. If let's say our clients are unable to perform certain activity because of their bradykinesia or hypokinesia, or they're freezing a lot, okay, that is when that we need to step in to teach them and practice with them a lot of strategies, all right, to perform the task. Okay, so similarly, if you realize that, hey, it's because of maybe some tightness of the hamstring, that's why they can't push themselves up in a good standing position. All right, that's when that they may need a stretching program instead. So only by identifying the right impairments, that's when that we can choose the right intervention to tackle the problem as well. So moving on, I would like to talk about the participation aspect in the ICF model. So participation is the role and involvement of the individual in life situation or in the society. So basically how the individual engages with their physical and social environment. So when our client have issues with this aspect, we call it as a participation restriction. So some of the examples of participation restriction will be that our client may have some issues with interpersonal interaction. For example, they have issues interacting within the family or with their spouse, or with a friend, they are basically unable to carry out a role as a husband, as a wife, as a friend, or as a parent, etc. All right. They may also have issue at work. Okay, they may find it difficult to return back to their job, for instance, or they may have issues with returning back to what they used to like to do. For example, he may be have a recreational group of basketball team, and this client just can't get back to their weekly basketball game, or this person may have issue going back to, for example, weekly church service, etc., etc. And moving on, we're talking about the environmental factors in the ICF model, and we're looking at the physical, social, and attitudinal environment in which this person live or conduct their lives. And usually for environmental factors, we are looking at external factors that is affecting or that has an impact in our client's health condition. So some of the specific examples for people with Parkinson's includes products and technology, for instance, certain assistive devices that our clients may use to help them to move better or to be able to complete certain tasks easily. All right, and also living environment. So they may be living in a cluttered house, or they may be living in a house with very narrow walkways. All these may affect how they are moving or have an impact in the way that they move or in the way that they are. All right, similarly, support and relationships, whether they have supportive families, friends, or even very supportive healthcare professionals with them, this does make an impact as well and makes a difference in how they are. All right, similarly, whether there are available services, systems, and policies that's around to support them. So, for example, certain barriers such as in public toilet, they don't have wet bars, or that they are living alone and there are no social support for them, or they are alone and they are unable to clear their house properly and therefore making their home environment very cluttered, and they do not have the ability to clean their house, and this can also impact the way they are. Last but not least, we are talking about personal factors, and here personal factors are mostly internal factors that affects their ability to, for instance, complete certain activity or limits or restrict their participation in certain tasks, etc. So some of the examples of personal factors in the ICF model includes age, gender, social background, and as we know, some of our clients with Parkinson's do have volatile emotions. Some of them may have extreme anxiety, they may have depression. So all these does play a part and does impact their health condition. And different people have different experiences. So for example, some of our clients just don't like to exercise. They may have negative experiences previously when they exercise. They might be very unwell or fatigued, or just don't feel good when they exercise previously, and therefore they have this negative mindset about exercising. So all these do play a part and do have an impact in their health condition. So after explaining the whole ICF model, I do hope that everyone understand that this ICF model has various components that are interlinked with each other, and they do interact with each other as well. So it is important for us to use the ICF model to come up with our client's problem list. So with this problem list, then we are able to formulate appropriate interventions that are targeting the right impairments, and also we are able to set realistic goals as well. So most importantly, with this information, we will also make sure that our clients are suitable for the exercise class. So in this part of the lecture, we are talking about the exercise class itself. And of course, the target audience will be clients with Parkinson's disease and Parkinsonism. So we should take note that for Parkinsonism, each patient or each client does presents very differently. We are talking about things like MSA, or like cortical basal syndrome, etc. So we should really consider when planning the class structure to make sure that the class is safe and also effective for this group of clients. So in this table, we can see that there are some special precautions to consider when you have this group of particular clients in your class. Alright, so for Parkinson's disease, we do know that they have poor balance, they have issues with their postural stability. Some of them may be deconditioned, and very commonly they have postural hypotension. So when you are conducting the class and when you are performing sit to stand exercises, it is important for you to just make sure that everyone is feeling okay and they are not having fainting spells during your class. Also, we know that this group of patients do have attention issue as well, and they have issues with safety awareness. So when you are performing maybe some dynamic standing balance exercise, or when you are performing some more dynamic exercises, just be mindful of this group of clients. So moving on for vascular Parkinsonism, they also do have attention issue as well as reduced safety awareness. And for PSP, definitely they would have poor balance and postural stability. They also have limited eye mobility. Alright, so when you're performing, demonstrating certain exercise, just make sure that it's within their visual field. Alright, and also they do have a reduction in their head cervical mobility as well. So with clients with MSA, multiple system atrophy, they have a really serious postural hypotension, fainting spell, and some of them may be deconditioned as well. So these are just some special mention for you to take note of if you have this group of clients in your class. So in this table, we are looking at the different class type. Okay, we are looking at advanced mobility, intermediate class, strong foundation class. It is important for us to make sure that we categorize and fit our clients to the appropriate and to the correct class type. Okay, so for the advanced mobility, it's for clients who are best functioning. Their exercise tolerance should be very good and requires only very short rest breaks. Um, for this group of clients, they should be falling very little. They may not be falling, or that they may only fall once this year, and they do not need any caregivers to be present during the exercise class, and they requires very minimal supervision only during the class. For intermediate level, we are looking at their exercise tolerance being not as good as advanced mobility. They only requires occasional rest breaks. They may be falling a little bit more often, more than once a year, okay, and that they require a caregiver during the class to watch over them, to help them a little, and they may require minimal assist during the exercise class. So for strong foundation, we are looking at clients who are a little bit weaker. They require small breaks, regular, occasional rest breaks required, and they may be falling more than once in the past year, and they will need a caregiver to be present in the class, and they requires minimum 2 moderate assistance during the class as well. So these are some of the exclusion criteria to the exercise class. So for patients with or clients with persistent and untreated severe orthostatic hypotension, they have chronic high blood pressure, or they have unstable medical conditions such as uncontrolled asthma or cardiac conditions, or that they have severe and acute orthopedic problems that requires close monitoring, for example, some recent fractures or any acute flare-up of their OAs or gout problems, or that they have severe osteoporosis with a BMD of T-score less than 53, or that they have some behavioral or cognitive issues that may limit class participation. So in situation whereby our client's blood pressure is high asymptomatically, so for example, their SBP is like more than 160, and however they have been cleared of medical fitness for exercise class. So you can still do your initial assessment, however, just proceed with caution. and do advise the client to monitor their blood pressure after the assessment and seek medical attention before attending the first class. So this is the end of our CE3 module. Please remember to attempt the questions in the learning activity to test your understanding of what we have just gone through. Okay, so remember to answer the short questions and case study. So this is the references that we have used in our training booklet as well as in this lecture. So if you have the time, you may have a look at the articles. Yeah, and that's the end of our module CE3. Thank you.